And thank you so much to Biz, Justine, and Cecilia for putting this whole amazing thing together. It's really going to be so great to get to be with you all in this virtual world where we're able to gather together across countries, as well as disciplines. And we're all here to really discuss and learn about how the ever-present reality of conflict, violence, security, or the lack of it, and trauma impact individuals and societies. Our organizers have put together a truly amazing lineup of top experts from a variety of fields that simply do not come together often enough. So I'm really excited to get to really connect with all of you across disciplines. It's going to be a really exciting couple of days. And I know there will be fantastic opportunities throughout both days for everyone to get to participate, connect, and really collaborate. So I'm thrilled to just get to kick the conference off with this first panel this morning. And joining me are three really influential voices in the trauma field, who all hail from the domain of clinical psychology, which is my area as well. So joining me up here are Drs. Adam Brown, who will be joining us just shortly, Dr. Yuval Neria, and Dr. Richard Tedeschi. And we really have the pleasure of laying the foundation for the following conversations that will happen over the next couple of days by talking from a psychological perspective about what trauma is, what it can look like, how we study it, and what it might mean for individuals and for societies over time. So thank you so much for joining us on this panel, The Legacy of Trauma in the Mind and the Body. And as Biz mentioned, we'll start first from hearing each of our panelists a little bit about their area of expertise. Then we'll get some good discussion going up here between everyone. And then we'll absolutely have an opportunity to answer questions from all of you. So please do engage, think, ask, comment, suggest, maybe even disagree. And we're going to have a really wonderful morning. So without further ado, I'll turn it over to Dr. Adam Brown, who has joined us. And thank you all so much for being here.
Thank you so much. And thank you for inviting me to take part in this amazing program. I'm just going to quickly see if I can pull up some slides to share with all of you. And I will keep it very brief. But I thought some visuals might help with some of the points that I'm hoping to make today. But, you know, as I've been thinking a lot about trauma on many levels and in different contexts, I keep saying that the work to understand this has to not be just the work of social workers, psychiatrists, and psychologists. This really has to be a multi-sector, multidisciplinary way of thinking, and really appreciate how interdisciplinary this meeting is. So when I was thinking about legacy of trauma in the mind of the body, I was thinking a lot about time and what it means to be exposed to trauma and how that sticks with us or doesn't. And where is the evidence in that, in our bodies and how we think, and what we've learned a little bit from things like cognitive neuroscience. And so I'll just spend a little bit of time talking about that and turn it over to the others on the panel. So one thing that I just want to recognize that I think we all know is that, unfortunately, one of the things that brings us together across the world and universally, although people in different contexts and from different cultures and backgrounds get hit with trauma more frequently, at some point, just about every person will experience some kind of upheaval, adversity, or trauma that they have to bounce back from. But of course, depending on where you live or your background, this might happen more frequently than others. But this is something that we have to think very deeply about as a public health issue. Also knowing that from data from the World Health Organization, that right now, one of the largest contributors to disability around the world are things like anxiety and depression, often driven by stress-related factors. So this very much is a major, major public health issue, was before COVID and will continue to be after COVID. Now, PTSD, for example, is not new. I'm sure everyone here is familiar with the term PTSD, but as long as people have been documenting what it means to be human, people have been documenting human suffering, whether that's going back to ancient Egypt, whether that's going back to old religious texts, whether it's looking at classical literature and poetry and music. Unfortunately, when people go through loss and interpersonal violence, and when they go through war, we should not be expected that many people will be transformed forever. And it impacts your communities at the moment, and it subsequently impacts your communities generationally after generation. So it's something that looks different depending on the available language and discourse and technologies at any given point, which is just interesting. But this idea of trauma being something that impacts us is something that we've known about for a very, very long time. And the historians in this call will certainly, be able to speak to that. I also just want to say that over the last couple of decades, one thing that we've really documented carefully, and Dr. Neria and others could obviously speak to this very clearly, is that we've learned that just because you're exposed to trauma does not mean that you are destined for a life of suffering. That many people, even in the absence of mental health and specialized care, if they feel supported, if they can get back to work, if they feel a sense of safety, over a couple of weeks, will get back to a level of functioning that was not too different than how they were functioning before trauma, before they were exposed to certain kinds of trauma. And what distinguishes different kinds of trajectories? There's many, many, many factors, and there's been many kinds of meta-analyses and reviews that have identified the variables that distinguish trajectories after trauma exposure. I'll just focus on neural circuitry for a second to suggest that there are ways we process trauma that could help us adapt or make it harder to adapt. And some of those key regions, when we think about legacy and time, really center within the parts of our brain that process memory and that help us to regulate our emotions associated with those memories. But where I'd like to offer a different perspective before I wrap up is just this idea of the future, that when we think about legacy, I think we often think about the past. But what I'd like to offer is actually how we imagine the future is equally, I think, as powerful in what drives our anxiety, our fears, and our feelings about recovery from traumatic events. Joe Ledoux, the neuroscientist from NYU, wrote a really interesting op-ed about it a few years ago, that with these powerful minds, we can keep trauma and threat alive for very long periods of time. Colleagues of mine like Donna Rose Addis and Dan Schachter at Harvard did some really interesting studies a few years ago showing that when we remember things, we use the same brain regions that are involved in imagination, that the brain in some ways cannot distinguish between past and future. And when we look at the minds of people with PTSD, for example, we see many of these same sorts of alterations and biases, whether it comes to how specific our memories are. People with PTSD tend to imagine the past and future with more trauma-related content. We figure it more centrally into our life stories, and the predictions we make about the future tend to be biased towards negative and trauma-related events. We've also shown in our research that when we ask people to recall memories and imagine future events, we found that combat veterans with PTSD and those without PTSD, we didn't see many differences. But when we asked people to recall positive memories and imagine the future in positive ways, we saw greater recruitment in the prefrontal cortex from those without PTSD compared to those with PTSD. So that absence of a positive past and a positive future was something we were beginning to document neurally in some of these studies. And then finally, I just wanted to offer a way to think about reclaiming past and future in an empowering way. One of the things when we think about temporality, past, present, and future, that underlies trauma is this feeling of unpredictability, that you've gone through something that you didn't expect that was horrible, and at any point more bad things can happen. One of the things we've been doing in our research is trying to change that perception by asking people to think about moments in their lives where they were faced with an event they never thought they could overcome, but somehow you managed to do that. We asked people to write about this, to tell us what it means about them as an individual, as someone who can be self-efficacious, who can get the supports that they need, and who can figure out ways to be resilient individually and collectively. And then we study how that impacts people's minds and their processing. And one thing I'll just leave you with before I turn it over to the others is that in some research we did recently, we found that when people recall memories of mastery, when they recall moments of adversity that they were able to overcome and then really think about those things, when we then look at people's brains after doing those kinds of exercises, we see greater engagement of emotional regulation circuitry, more so compared to people who were in other conditions, just writing about other kinds of events. But we know that trauma and PTSD in particular can alter our past, present, and future, there are things we're learning now that can reclaim some of that, where we can develop a greater sense of controllability and mastery, and hopefully allow us to adapt within our communities in really positive and healthy ways. So I will stop there and turn it over to others. Thank you all so much.
Fantastic. Thank you so much, Dr. Brown. Really getting at the question there of why, when you have two people who experience the same event, is one person able to recover, and that event really just becomes a painful piece of their history, while someone else might find that that event really stays with them, impacting their memory, their mood, their physiology, and their behavior. And that question has been a mystery for a long time that research such as yours is really starting to unpack. So thanks for sharing that with us and giving us a little taste of how maybe the power of thought, specific types of thought, can really influence the brain and a path towards healing. I know we'll hear more about that from others. So now, Dr. Yuval Neria, I will pass the baton to you.
Okay, thank you. And thank you for the invitation. It looks like a very cool opportunity really to engage with different perspectives on trauma. Let me make sure my slides are here, and let me close my email. Okay, let me bring it here. So, actually, my talk is slightly overlapping, or at least, you know, the subject of interest is overlapping with Adam content. So that's interesting and promising. I would like to basically focus in these couple of minutes on what's going on in the field to the best of my understanding. And as Adam was kind of pointing to, one of the most interesting question is whether among those who are exposed to trauma, who will eventually develop trauma-related psychopathology, which is enduring and debilitating, versus those who were either remit or recover or stay healthy with or without treatment from trauma-related psychopathology. So this is really the basic, I think, question in the field. And of course, as you know, mental health professionals who are interested in clinical work, those of us who are interested in psychopathology following trauma exposure have a lot to really unpack and learn. Those of us who are interested more in resilience and meaning making and positive outcomes of trauma will be very interested in the group that either didn't develop psychopathology or remitted from psychopathology. And I think the second trauma is really about treatment. And so if we zoom on those who developed psychopathology, I think the main question is who and why will be benefited from treatment. It's not clear that everybody will be benefit from treatment. In fact, only about half of the people with PTSD, for example, are responsive to current treatment. So what about them? Why they responded to treatment in this way, not the other? And what about, you know, millions of people who are exposed to trauma and develop psychopathology who are not benefited from current treatment? So those are really the main question to my mind in the field. And as you know, trauma is very common, and therefore trauma exposure psychopathology is very common. And traumas can be either single or time limited, single and time limited, like car accident, or trauma can be ongoing and repeated. And there is huge amount of research suggesting that the effect of ongoing and repeated trauma, like sexual abuse during childhood or sexual abuse among women, or even long-term combat experience, those type of traumas are more damaging, and people are coming back more injured. And the question of loss or death, and the experience of death, for example, in a family, is always very impactful. And the field didn't yet come to terms with the question whether loss of life, for example, among elderly, is even considered traumatic event to those who are stay behind. And another complication is that the trauma is not also very common in general. It's very common by almost every psychiatric patient. We can see trauma history not only in PTSD, but also in depression and schizophrenia and bipolar illness and general anxiety disorder and borderline personality disorder, and which makes really the focus on PTSD to be a little bit kind of random, and perhaps because PTSD is such a huge kind of PR, you know, we love to study PTSD. It's cool, it's compact, and complicated though, but at least there is a time point that we can follow and go after psychopathology. What's going on in the linkages between trauma and other disorders, such as schizophrenia, bipolar illness, is very, very different. And as research was showing, exposure to trauma may have a role not only in the onset of the disorder, but also about the trajectory or the temporal trajectory of the disorder. Now, I don't have a lot of time at this point, but you know, it's an opportunity really to zoom in on the first study that I have done actually in my PhD studies. This is a group of prisoners of wars from the Yom Kippur 1973 war between Israel and Egypt and Syria. And those guys here, you know, those people who are having a hard time really even to look directly have been soldiers only a day or 2 days ago, you know, and see how beaten and depressed they are. And those guys spent 42 to 60 days in captivity, were tortured, humiliated. Many of them were sexually assaulted, and really very difficult, ongoing and repeated exposure. But if you look at the data, and this is data that came out about two decades after they came back from captivity, you see that only about 1/4 of them developed PTSD early on after coming back from captivity, which suggested about 75% of this population, despite horrific experience, torture, humiliation, being confined, being hungry, being thirsty, remain pretty much resilient. And if you look at here's a difference between PTSD and combat exposed soldiers, you see that, yeah, the type of trauma makes a lot of difference, but yet the response to trauma is varied, and perhaps the main outcome of trauma is really resilience. And if you look at another concept here, which is very important, recovery, you can actually may come with the conclusion that that our brain is hugely plastic, and we expect not only resilience right after trauma, but quite amount of plasticity over time. You know, our brain is responding and perhaps recovering if it's doing its job well. And let me just finish by one of the most important, you know, research models that I've used a lot in my studies, especially the neuroimaging study that I've been done for a while already, suggesting that, again, coming back to the question of resilience or resistance, suggesting that all of us have pre-existing sensitivity levels or genetic makeup, and then we are all very likely to be exposed to stress and trauma over the course of our lives. And then there is a very interesting process in which right after being exposed to threat or death or injury, you know, there is kind of initial consolidation of the fearful experience in our brain, especially between amygdala, hippocampus, and prefrontal cortex. And then the question will be, what's next, right? And what's next is whether we will start to express fear over time, immediately after the trauma, will take some time after trauma. And there are basically two options here. The first option is really pathology, and the second option is resilience and recovery, with kind of a bunch of theories that really explained the pathological pathway, and kind of less of a bunch of theories on the resilience side, really explaining what makes us resilient, especially being able to distinguish between fear and threat is a key component. So perhaps we'll have time to talk about it later. Thank you, everybody.
Thank you so much, Dr. Neria. Really introduced us to some key concepts there, including the incredible resilience that humans have in the face of horrible things, and trying to really operationalize what resilience is, how we get there, and what we can learn from that for individuals who unfortunately aren't as lucky and do face psychopathology as part of the aftermath of trauma. And really hitting on this important point that with ongoing and repeated exposure to trauma, it's much harder to treat, seems to be. And that's sort of the common ground that we all have here from across different disciplines, is violence and conflicts that tend to be ongoing for months or even years. And so I think that's really the population that we'll need to hone in on here, is what do we do with individuals and even large populations who've been through these kinds of events for a long time. So Dr. Richard Tedeschi, I will hand the microphone to you. Thanks so much for being here. You are on mute still, Dr. Desky.
So I thank you for allowing me to speak today, and I'm going to just talk you through a few concepts that build on what we've already heard from Drs. Brown and Neria, and come out of my work on post-traumatic growth for the past 35 years at University of North Carolina at Charlotte, and then more recently, since I retired from the university, with Boulder Crest Foundation, which is which I've been working with the past 5 years as we've established this foundation to treat military service members and first responders with trauma histories in a different kind of setting that's not clinical, and where we're getting, I think, very nice results in treating these people who have been have not been successful in receiving trauma treatment in the past. So first of all, I want to redefine how we think about trauma, and the way we talk about it in our work is we think about trauma as a challenge to the core belief system. the beliefs that we hold and think about very rarely, except when they don't lead to predictions, or their predictions that they lead to are not verified and validated by events. So we have core beliefs about how predictable life is, how controllable it is, how vulnerable we are versus safe, how benevolent the world is, our own self-esteem, the degree to which we're moral, all these beliefs that we operate on day to day that we just take for granted. And we define trauma then as situations which call these beliefs into question, sometimes called the assumptive world, and work by Ronnie Janoff Bowman at Massachusetts, for example. So when that happens, it creates a lot of anxiety and confusion. Dr. Brown talked about anxiety and its crucial role in trauma response. And we're thinking that the anxiety is caused to a great degree by a failure to really understand what's going on with us anymore. We can't believe these things have happened. We can't believe what we've done or others have done. And we also think that this is a challenge to our narrative, our autobiography that we've been developing. So life isn't going according to plan. Now, the challenge to these beliefs can lead us to a lot of anxiety and confusion, but eventually we have to reconstruct this belief system. We need it to live on. It's like an infrastructure for us psychologically, just like a city needs an infrastructure in order to function. Electric grid, roads, buildings, and whatnot. And so there's an earthquake that destroys that infrastructure. Psychologically, we experience an earthquake. We have to rebuild. And in rebuilding, we can come up with a system of beliefs about our lives and ourselves that's superior to what we had before, like a better infrastructure. And that superior set of beliefs and understandings about ourselves and our lives and how to live is what we call post-traumatic growth. So we've heard about resilience. Dr. Neria was just talking about that. We're talking about something that's not bouncing back to where we were before a recovery. We're talking about something that goes beyond that into a transformed life, into a better life, a way of living that's superior to what it was before. And generally what we see is people talk about, they've reported to us, changes in how they relate to other people in more compassionate, empathic ways. They talk about appreciating their life more and having more gratitude. They talk about possibilities that open up in their lives that they might not have explored before, new things that they're going to do, new priorities for themselves. They talk about the strength that they see themselves that they hadn't had before because they've been forced to go through something very difficult. And they sometimes reconstruct their spiritual and existential beliefs about the meaning of life, their purpose, what they're going to do with their lives. So these are the transformations people have reported to us. And to get there is a struggle. This is no simple matter. This is very difficult. And we have to go through certain kinds of phases with them in order to help them facilitate this growth process, which is natural, but we can facilitate it. And the ways that we've helped, I think, are superior to what we usually think of as the standard therapies for PTSD, like prolonged exposure and cognitive processing therapy. Although it has some connection with these, we have a different outlook and we have a different approach where we first educate people on what has happened to them is not because there's something wrong with them. It's just the natural reaction that people have to being under threat and danger. And so people have to learn about that. They have to learn emotional regulation. They have to learn how to disclose to people they find safe emotionally so that they can start to reflect and put together their new belief system and their new narrative, the new story of who they are, what kind of life they're living, and their future orientation, like Dr. Brown was talking about, their orientation towards a new future that would include acts of service, which we think are really important in making sure this is a permanent kind of change where people start to live differently because they take their trauma experiences and turn them into some way to benefit other people. We do all this in our work at Boulder Crest through a peer-based program. We have no mental health professionals providing these programs. It's all peer-based. with people who are military service veterans or first responders who we have trained up, who operate as people who are culturally competent, emotionally safe for the people who come through our program. So this is a little different viewpoint on what trauma involves, what trauma, how we define it and how we respond to it, and what can happen when we encourage people to live differently in the aftermath of trauma, not just deal with their symptoms. And as a result of all this, they become stronger and more capable.
Could you please?
So this is a very good way, I think, of bringing together a lot of this work on resilience, because post-traumatic growth leads to a more resilient future for people, just like a city that's rebuilt to higher standards. So with that, I'll leave you to ask us our questions and lead us in our discussion.
Thank you so much, Dr. Tedeschi. And this is a really important concept, this idea of post-traumatic growth, where individuals can take a horrible event that really turns their world upside down, their understanding of themselves, others, and how the world operates, and somehow turn it into something that ultimately leads to further development for them, maybe more meaning, more purpose, even more compassion, gratitude, and joy. And it's almost a kind of contradictory understanding of what trauma can be, and yet really can have such positive outcomes for those who manage to get there. So really important to be looking at how can we make this happen for others. And we've gotten to hear a really wonderful overview of where we are in the field of trauma, understanding the impacts of trauma, what hopes for recovery look like, and even growth. However, it seems that much of these processes really take place from the safety of the aftermath of trauma or violence. And so there's an important question remaining here, especially in this world we live in where conflict might be ongoing for many years or even for generations. And so I'm wondering, what do we do with those situations? Can individuals or communities that have been suffering these repeated and ongoing traumas and continue to suffer from them heal? How can they recover when the situation is still ongoing?
Well, I guess I'll start, okay?
Sure.
All right. You know, I think a lot of the concepts that we have that apply to individuals apply across individuals to groups and systems, to our communities, even to nations, perhaps. So when we are experiencing shared trauma, for example, like perhaps we can think of the pandemic as part of that, maybe. When we experience a shared trauma, maybe our systems, our ways of operating in our communities and whatnot are challenged as well. And it's time to reconsider some of these things and to make changes in the aftermath. And I think that there are examples historically of societies which have done just that. You know, I know we have political scientists here, like Biz Herman there. So, so for example, I would think like Japan after World War II. I mean, change from militaristic to more or less a pacifistic society. I mean, terrible trauma of that war, and it shifted them into maybe a different way of thinking about the place of the military and their imperial motives that got them into such a mess. So, I mean, trauma does not have to remain with us as suffering, like Dr. Brown talked about. That doesn't have to be the ultimate outcome. And I think that can be the case beyond the individual level.
If I could just piggyback a little bit on those great points. I mean, I think the thing I would add is I'd like us to consider the individual, the social, and the political. that when people are in context, when there's ongoing violence and trauma and lack of safety, we have to think about ways that we can support people's well-being that I think goes way outside traditional forms of psychotherapy. I think we really have to be thinking about the communities that people live in and where people can feel safe, where they feel like they can politically engage. There's some really interesting work from Turkey from many years ago that found that activists, for example, despite being exposed to really serious trauma, were less effective because they were proactively engaged in responding to the traumas that were around them. And thinking just about, access to basic needs, whether it's, food and water and other kinds of basic connections to communities and care and things like that. So, when we're thinking about humanitarian crises, or we're thinking about ongoing stress and trauma, prolonged, protracted wars, things like that, I would say that the view of response to trauma really does need to be collective, and it needs to be very broad. And there's some really great articles about the difference between post support and support within spaces where there's ongoing, and just the importance of creating safe spaces where people can have a sense of continuity, where people can be connected to basic ways that they typically get support that might be different from long ongoing therapy. I would also draw people's attention to what we call mental health and psychosocial support. So there is a huge movement, especially coming out of the global South, that has recognized for a long time that there may never be opportunities to provide extensive sessions of therapy or other kinds of support. But nevertheless, people have worked really successfully in unstable regions for a very, very long time. And I would look to models coming out of the WHO and other UN agencies partnering with NGOs to adapt and implement brief mental health care interventions in places where there may not be a lot of resources and when there is a lot of uncertainty. But I think, for example, the US in particular could do much better on bringing those models here, because there's actually a pretty extensive knowledge base already that I think we can learn from.
Can I jump in? And I think it's a wonderful really direction to take, kind of the interplay between the individual and the society at large. And I guess, the pandemic was a great case study really to look at that. And so we had a virus kind of spreading globally, and in a way that was kind of amorphic and really difficult to conceptualize, even whether it's trauma or stress or what, but the data that coming from different parts of the globe suggesting huge spike in anxiety, depression, to a certain extent PTSD, but especially anxiety, depression, substance abuse, jumping to 50, 60% of almost any given population in the kind of height of the pandemic. And if you look at what happened to us then, and actually, the fact that we are doing this conference virtually is a testimony for that, right? So we withdrew to our homes, right? We stopped engaging with most of our social network, family, friends, and people remained, many remained lonely, and pretty much in distress. So the idea that both, I think, Adam and Richard are speaking about is a very interesting one. What happens to the individual in the context of trauma when there is no way to first, kind of a meaning-making, processes, and second, there is kind of the social network is really breaking up, right? Breaking up, almost completely breaking up. And for me, this is really key in understanding what's going on in trauma, and why is it that some of us will eventually develop psychopathology and some of us will not. What's bringing us really to the breaking point? And I think what's bringing us to the breaking point is the fact that we are not being able to carry any more kind of our roles in identity and identification within a social network. We are withdrawn and we are cutting off, and we eventually, stop being synced, which with what's going on around us.
Thanks so much for all of your thoughts on that. And, it's really leading right into some great questions we're getting in the chat from the audience. What I heard from all of you there is the importance of community support, social support, and whether that's something else like the peer-to-peer groups in Dr. Tedeschi's work, or community organizing, safe spaces, opportunities for engagement. Maybe this is one of the ways that even without expert level care, we can heal. And Dr. Neria really pointing out how in something like a pandemic where isolation is imposed, and also in many other situations, refugee situations where you're cut off from family, how exactly do you get that kind of healing? Don't have access to expert care and don't even have access to your community. And there are a few questions here from folks wanting to hear a little bit more about that peer-to-peer program that you talked about, Dr. Tedeschi, and maybe there can be a little bit of discussion and dialogue on how we can take some of the principles we're talking about and apply them to situations across the globe, across cultures, across different kinds of situations of safety and conflict. So any thoughts from each of you, and maybe Dr. Tedeschi, if you can start by sharing just a little bit more about the peer-to-peer groups, that would be fantastic.
Certainly. Glad to do so. We're trying in our programming to implement a concept that myself and my colleague Lawrence Calhoun at UNC had described years back, which we call expert companionship, and trying to emphasize the fact that, as Dr. Brown mentioned, most people don't have professional mental health care in the aftermath of trauma, and they still do generally well. Why is that? Well, we're thinking when we've done our research, we found that these are people who locate in their environment someone who is an expert companion, we call them, someone who is able to listen to them, who is accepting, non-judgmental, who will be there for the long haul with them through the traumatic events and help them figure out, what kind of future to move into. So if people can find folks like that, they'll do better. And what we've done in our program is we've had people who've gone through the program themselves who want to become part of our program, become what we call peer guides or expert guides, implementing this expert companionship model. So we don't train them as mental health professionals or therapists, but we train them in how to be respectful, accepting, be good listeners, to learn from the people that they're working with so that those people can teach, what their trauma circumstances are about, and teach those expert companions, those peer guides, how they're trying to live better. And so we have actually a manualized program. We have a 200-page manual for this program, but it's not like manualized therapy, because it includes a lot of alternative approaches. We work in a group setting all the time. It's not individual, small group, 6 to 8. And we do a lot of non-traditional kinds of things. We have people work on emotional regulation by walking in labyrinths and doing archery and working with horses. So you can't implement some of these things in an office. So we have beautiful natural settings that we work in. And so we think it's the natural setting, the calming atmosphere. We think it's the respect that they get from their peers that are implementing these programs. It's the philosophy of growth that we get on the table with them right away. And then it's the program itself, the content of the program. So it's those four elements that we think produces good results. And we've published some of our results, which show great symptom reduction, even though that's not the focus of the program. We're not so interested in that. We're interested in producing wellness, health, healthy living, growth, and ultimately service, where people go back to their communities, serve their families and other people in their community. Before they leave our program, we help them develop a kind of a plan for how they're going to be of service when they leave. So we're seeing this as a way of planting some seeds in communities where these people who thought themselves as broken go back as true heroes in the sense of they've learned something from their terrible experiences, and they want to be of service to their communities in a new way. So that's kind of what we're about.
Just to add to that, Richard, I mean, it's interesting to me that I think our field, meaning clinical psychology in particular, I think is really thinking about giving psychology away as much as possible. I think we are at this really interesting moment of capacity building, where we are recognizing that, while you could become a specialized therapist, that there are a lot of really basic things that we all could be doing to help each other recover from stress, adversity, and trauma. And we're now really studying this carefully and building, I think, on a lot of local historical practices and combining them with cognitive behavioral therapy to see the outcomes that you're talking about. And our team, we've been using something called PM Plus, or Problem Management Plus, which was developed by the World Health Organization, where we've been training people who are lay therapists. We've been delivering this remotely during the pandemic. We've been doing this in Colombia now with Venezuelan refugees. And it's a 5-session intervention where people with no mental health backgrounds are delivering really brief interventions. And it's not meant to be specialized care, but we know, as we've been talking about, there's rarely access in many parts of the world to specialized care. And so what are ways that we can think differently about, if we want to think about the legacy of trauma, and if we want to interrupt that so future generations don't suffer, how do we build communities of nurturance and care in order to interrupt that? And I think some of these strategies, taking it out of the clinics and bringing it into the communities through careful partnerships, is a really exciting direction that I think a lot of people are moving in.
I want to comment on that. I think that's exactly right. I'm a clinical psychologist, and I do my clinical work, individual therapy and whatnot. But I realize that, through my work at Boulder Crest, what we're trying to do is take what we know in clinical psychology and elsewhere and apply it in a way that's going to have the greater impact. Not me, seeing individual people, but developing programs that make use of these naturally occurring expert companions in communities. I mean, these people are all over the place. They may be teachers, they may be coaches, they may be clergy people, they may be neighbors. They're everywhere. If you give them a little bit to work with, they can do a lot of good, more than you would ever be able to do, with every individual client that you see in a traditional therapy.
So I would like to counter it a little bit, if possible, just for the sake of the protocol. I'm very much for capacity building, and I don't think that emotional help should be the job of clinical psychology, social work at all. I mean, and there there is great evidence coming from, you know, programs in Africa and Latin America and also the US suggesting that. But for somebody who is focused on psychiatric research, for although I'm a clinical psychologist as well, for so long, you know, I must say that for example, we have a treatment center for veterans who are unable or don't want to seek care at the VA, and they come to Columbia Medical Center for purposes of evaluation and treatment. And we have a range of treatment, and we try to do personalized treatment, going all the way from CBT, IPT, and you know, medication, etc. And I'm well aware to the limitations of current treatments, both pharmacotherapies and psychotherapies. I mean, as I said before, I think there are a lot of people with PTSD who are unable to be helped by such programs. But nevertheless, you know, to see patients who are chronically traumatized, you know, suffer from full-blown PTSD, and people who really need very focused and better help, you know, I think that there is still a role for an important one for both clinicians and research who is informed by clinical work in order to, you know, to help those people really. And this is about 10–20% of the people that among us, you know, in our society, who are dealing with severe depression, severe PTSD, anxiety disorders, well, cannot be helped otherwise. So I just want it to be here, you know, because we, you know, we tend to kind of, I don't know, forget or romanticize a little bit what we do for people with mental illness.
Putting all these thoughts together, I'm imagining some kind of a layered care system might be ideal, where you have sort of expertly trained clinicians at the top who are passing down core principles to trained but not quite expert level caretakers, who are then also connecting with the community, making translations, culturally appropriate translations to the different settings, and really finding who are those community members who can be agents of healing, of community building, of connection. And I've just been loving getting to hear about so many kinds of different international projects and research studies going on. I think that's really important. There's a question here in the chat asking, do we see traumatization and growth across different social and political settings? And I'll add in cultural settings too there. And then I just want to bundle that with another question that came up, which was about, can trauma be epigenetic? And we've heard this idea also of maybe intergenerational trauma. And how can we think about that in the context of wanting to use community, wanting to use natural healers within different settings to make change, and that there might be this legacy of trauma that moves from one generation to the next?
Maybe we can pick up the last question first. I think there's very compelling evidence that trauma can be epigenetic. I mean, I think there's a lot of really sophisticated neuroscience, biological research showing that RNA methylation, changes in how the brain processes stress, can be altered depending on your history, intergenerational history of trauma exposure, even down to the level of what trimester, you know, someone was in while they were pregnant might increase stress sensitivity or behavioral changes in their kids. Dr. Neria might speak even more. I think even in Israel, there were some very careful research done looking at, during different wars, and there have been medical records of people at their age at the time of exposure and then looking generations out. Not speaking from the biological angle, but I'll offer an intriguing finding that we're finding in our lab. We're looking at memories of how much you know about your family histories. And one of the things that we find is that the more knowledge you have of your mother, father's history, your grandparents' histories, good or bad, traumatic or not, there's something really important about knowing these stories that we carry intergenerationally. And knowing these stories is associated with lower levels of depression. And just the other day, we published a study, not only looking at your biological family's history, but even knowing people in your community, your best friends. If you know their histories more, if you know their sort of origin narratives and things like that, you're able to contextualize your own stressors better. So, we're thinking about the legacy today, but really being able to hold intergenerational legacies, I think, is a really important way that we can help normalize and contextualize and give us hope about ways of coming out of our own traumas. And so when we think about intergenerations, one thing I would like to just offer is continue to make space for ways that we can learn from people from before us as a way to integrate those stories, learn how people from before us overcame adversity, and think about the lessons learned in those narratives and in those memories. It's been a really intriguing thing we've started to look at in our lab.
I love that idea. I think that's really compelling, and it makes me start to think of all sorts of reasons why this may be. It may be your findings about these memories may be a proxy for the degree to which people are well connected to their family members and their communities. It may be that knowing this information allows people to have a more detailed and meaningful story of who they are and their own identities, which can help people move through traumatic circumstances without losing themselves in a way. So I think that's really great that you've hit upon that question and are looking into it. It just makes me think of these different possibilities.
I think the whole idea of memorizing or remembering is a very interesting one. And I mean, there is, again, it's all sorts of very kind of surprising directions that it can take. So I think we are all kind of struggling with the legacy of not only of trauma, but the legacy of psychoanalysis, right? And the question whether we should expect ourselves, our kids, our patients, to speak, whether talking trauma or speaking trauma is a good idea or not a good idea. And I would like to argue that it's not necessarily a good idea. So, for example, if you ever treat, a chronic PTSD veteran, they tend to talk and talk and talk and talk about the same things forever, because unless there is a way really to unpack, the memory from the emotion really, and in a way that will make the patient not, experiencing the trauma as a broken record, right? So talking is very important if it's coming with, as I think Adam was suggesting, with, kind of a sense of integration and knowledge and kind of expansion of meaning, right? And otherwise, talking can be nerve-wracking or anxiety-provoking, or merely, not helpful. And that's why the idea of forgetfulness or forgetting is also an important idea, right? I mean, the question is, especially when we talk about refugees with, severe traumatic experiences, or veterans or sexually abused people, we would like them to experience some forgetfulness. We would like them to not remember really every or any detail of the traumatic experience.
So really important that there's some type of meaning making, and whether that's through holding histories and traditions or contextualizing one's own experiences, that maybe that's really a key piece of this. And that there's a great question in the chat here about what about the role of spirituality? Where does that come into play? And maybe thinking about how across cultures, spirituality can look very different, different religions, different faiths, different what's the norms. And so is this a concept that we can leverage for healing when contexts or traditions might be very different?
Well, in our work on post-traumatic growth, we talk about spiritual and existential growth and change as something that many people engage in and report. And I think Dr. Neria has probably worked in working with the veterans in his program, runs into the concept of moral injury, that many people are put in situations where they either observe or perform acts that are contrary to their moral code, and that's a big part of the trauma for them. So I think if you're going to work in trauma, you have to be able to be comfortable in dealing with spiritual and existential issues with people. That's really crucial. I mean, trauma is existential. It's a question of, human existence and suffering, as Dr. Brown pointed out right at the start today. It's just part of living, and everyone's going to experience some version of it, some degree of it. And so we have to come to terms with this and understand the role it plays in our lives. And I think, the Buddhists, I'm not a Buddhist, but when I understand about Buddhism, they have it right about so much of the existential aspect of suffering, that we have to engage in it. We have to face up to it. We have to learn from it. We have to understand what it has to do with making us human. So that's got to be part of a really comprehensive approach to people who are traumatized.
And I'll just say that perhaps in response to all the quarantining we've been doing, I've become very interested in the power of nature and nature therapy. And just, there's more and more research. While it's not a cure-all, I mean, nothing is. It's really interesting to read what, even if you're not in a forest, but just being in your local, park or playground and really just taking it all in. And I think there's some connection there to spirituality, just being connected to something much older and bigger than you, as a way to help kind of ground you in whatever moment you're in.
I think that's really true. And that's why in our Boulder Crest programs, we have them always in rural settings. We own a ranch in the high country of Arizona, out in the middle of nowhere. It's beautiful. We've got another place in Virginia in the foothills of the Blue Ridge Mountains. And we've got other retreat centers we work with across the country, all in natural environments. That I think that's a really important piece of the healing. And it's so hard for some people to find that in their environments. I mean, especially if people who are daily exposed to trauma are often in nasty urban environments, frankly. And to find a way out of that so they can understand what it means to be human in a more natural way, might be an important part of what we can start to do for some people.
We've got just a couple more minutes we can spend here. And this has really just been a fantastic discussion already, getting to start to understand how we can take these concepts from psychology and move them into other fields, other domains, other places geographically. So wondering if anyone wants to just leave a key takeaway point or something that we haven't touched on yet, or maybe a question to keep pondering throughout the next 2 days that we're all here together. And then there'll be an opportunity for those who want to continue this discussion for a few more minutes to opt into breakout rooms. Before 12:30, there will be the next event, which is going to be a wonderful networking event. But just a couple minutes here before our breakout room option, any final thoughts to leave folks mulling over?
You know, I think that's, you know, the next chapter in trauma therapeutics is perhaps psychedelics. You know, people mentioned, you know, the importance of connection to nature, and, you know, and nature includes, you know, all sorts of kind of potential promise, you know, for big insights. Psychedelics are really becoming more and more kind of a prominent and how would I say, you know, promising drugs. So psilocybin, for example, you know, mushrooms are experimented forever in certain areas around the globe. They are starting to get into psychiatric research in anxiety, PTSD, depression. And the question is again about the brain, whether, you know, the traumatized brain can be benefited by a compound that will kind of open up, you know, opportunities for bigger, greater thoughts, experiences, insights about who we are, our connections with other human beings, connections with the nature around us.
Maybe my quick question, building on that for the future is, you know, maybe where I started was that we know trauma creates suffering. We know that, and we know a lot of things that can help people heal. And as Dr. Neria said, there's some really exciting things on the horizon. But what I would like to, I guess, ask this group to continue to think about is, as we spend, you know, our lives, maybe the lives of the next generation, trying to make the world safer and more equitable and a place of greater nurturance, how do we connect our knowledge of trauma to bring mental health more to the forefront of what we do politically? So as people are working in political spaces to end injustices and violence and, you know, everything else people are working on, where does mental health figure into those movements and activism and sustaining political change in more deliberate, explicit ways, where I don't think it's really lived yet, but I would love us to take up that question a little bit more.
It's such a great note to end on, and really does invite in experts we have from all of our other disciplines here. So with that, I will just thank you all once more for being here, for sharing your perspectives, for your great questions, everyone who's here in the audience in the chat. For those who would like to join breakout rooms and continue the discussion for another 10 minutes, please feel free to do that. You can click on the breakout rooms button and hop on into a smaller group discussion. And then at 12:30, we will have our next event, which will be an awesome networking event. Thank you so much, everyone.